Fajr, please. Hello, everybody. Good evening to colleagues who have joined from India and neighboring countries, and good morning and good afternoon to all of you who have joined from other parts of the world today. Welcome to all the distinguished faculty, participants, patient advocates who have joined in today for this webinar. On behalf of Thalassemia International Federation, Thalassemics India, Project ECO, and Postgraduate Institute of Child Health Noida, I extend a warm welcome to all of you to our eighth of the advanced webinar series on thalassemia management. Today, we are focusing on a very important topic, which is splenomegaly and hypersplenism in thalassemia. How can we prevent and how can we manage? A topic which is extremely important for the patients that we manage in our country because as you know, majority of patients, because they are not transfused very well early in their life, they by the time they are like in their mid in by like 5 to 10 years of age, they present with the significant splenomegaly, which becomes again a challenge as they grow up further. So it is my privilege to serve as the moderator for this session. And we are honored to have as our chairperson, Professor Michael Angastiniotis. He is from the Thalassemia International Federation. He's a medical advisor and he's a pioneer in thalassemia management, and he's been an advisor to us. And so I welcome you, sir, for your remarks from TIFF.
Okay, thank you very much. In fact, I was hoping that Dr. Andrea Leferiu will be able to make this welcome instead of me. Unfortunately, she was in another city and hasn't managed to get here in time. As Dr. Nida has said, the subject today is very important. It's very important because the whole issue of splenomegaly, hypersplenism, splenectomy becomes very important. Splenectomy can lead to serious side effects along the patient's life. Thrombophilia, severe infections. Therefore, if it's possible, we need to prevent it. So we're talking about an issue which belongs to everyday care of thalassemia patients. And I'm hoping that the speakers will actually emphasize the need both of prevention of splenic involvement by early transfusion and also by monitoring and reducing the number of splenectomies in a patient population. Over to you.
Thank you very much, sir. Now I would like to introduce Mrs. Tuli ma'am. Shobha Tuli ma'am does not require an introduction in this crowd. So she's Secretary of Thalassemics India, as well as the executive board member of Thalassemia International Federation. And she's one of the loudest voices in thalassemia in our country currently, a tireless advocate for persons with thalassemia and their families. So she's one of the co-organizers for these webinars as well. Welcome, ma'am, for the context setting for today.
So greetings and namaste from my side. So welcome to session 8, which is being this webinar is hosted by ECO India and PGICH Noida under the banner of Thalassemia International Federation. As we all know that today's topic is hypersplenism in thalassemia, which is very, very important. And the experts will be talking about the prevention and management. So on behalf of Thalassemics India and Federation of Indian Thalassemics, I once again welcome Dr. Michael Angastiniotis. We'll be missing Dr. Andrea Leferiu. Maybe she gets time to join us later. Dr. Antonio Pica, Dr. Amita Mahajan, Dr. Aditi Tulisian, and my friend Dr. Nita Radhakrishnan. As per my understanding, I think about 200 registrations are there to attend this webinar, and most of them are going to be from the medical community, but I'm very sure that this webinar will be attended by some patients and the thalassemia parents as well. I'm sure the present experts will be talking about the prevention, which is so important for such an important topic, and they will be also talking about the management, and then they will be talk about the splenectomy also, and there's some case studies will be also discussed in this webinar. If patients and parents are listening, I'm sure I'm not going to go into the medical side because the doctors will be talking about them, but I have a request to make that please stay till the end of this webinar because it's very important topic. And we all know when it is talked about that it has a connection with the blood. And you might say, and you talk about that there is not enough blood in our country and the availability is an issue. But what I want to say here is that at least, the tier 1 and tier 2 cities where such kind of problem does not exist, where with the patients and the parents can manage it very well. At least we should try to see that splenectomy is not the only option, because as the doctors will tell you that why it is not the best option. So the doctors will be talking about how to manage it. But what I want to stress is that I am the person who believes in the prevention. So let us all listen today and have some learnings and try to follow it up in our daily routine when we are managing our patients and that from the thalassemia community. That such a situation does not arise because it's not a comfortable situation. That's all I have to say from my side. So welcome once again, and I'm sure this webinar is going to be very informative. And over to Dr. Nita, please.
Thank you, ma'am. Now, for our speakers. So today, as usual, we have two speakers in every webinar. It is my distinct privilege to introduce our international speaker, Professor Antonio Piga. Professor Piga is Professor of Pediatrics and Dean at the Medical School at St. Louis Hospital, University of Turin. He is internationally recognized for his seminal contributions to the management of thalassemia, and he is an excellent speaker. And so in India, we've been fortunate to hear him in person in the last couple of years very frequently. Thank you very much, sir, for taking all the pain to come here and whenever we have invited. And so in our lecture today, he'll be addressing the pathophysiology of hypersplenism, the preventive strategies for splenomegaly, and evidence-based approaches to managing splenomegaly and hypersplenism with what is the current standard of care as well. This will be followed by our Indian speaker. So Indian speaker is Dr. Amita Mahajan. So in every topic, we have an international view and an Indian view. So the Indian speaker brings in the practical issues surrounding it, the epidemiological issues surrounding it in India. What are the practical ways of addressing the same problem? Many a times, what is evidence may not be able to we may not be able to apply that exactly the same way in a low and middle income country, because there are many others who have joined in from other Asian countries as well. So it would be a similar scenario there as well. And also, splenectomy, the post-splenectomy care, etc., would be extremely difficult, and morbidity increasing for splenectomy, so we don't splenectomize many children. So all of that will be discussed. Dr. Amita Mahajan is a senior consultant and head of pediatric hematology oncology at the Indraprastha Apollo Hospitals in New Delhi. And she works closely with Thalassemics India and has been part of our thalassemia guidelines, which has been released from the Indian Society as well in 2023. So I invite both our faculty members, and I would request Professor Piga to proceed with his talk. Over to you, sir.
Thank you very much for this kind introduction, and I will not enter in so many details in 20 minutes because the topic is very huge, but it's very interesting. And so let's start obviously by the spleen structure. So we see here the spleen, where we can see that there are nodules that are the so-called white pulp, and spaces that so-called red pulp. And if we go to enlarge, we can see that the white pulp is made of cells and is dealing at most with the immunological function of the spleen. And the red pulp is made of cells, obviously, but also by spaces, very large spaces. Here in this preparation, empty of blood. But if we see the same preparation, here more enlargement, if we see the same preparation full of blood, we can see that this part of the spleen may contain a huge amount of blood and of cells that dealing with the main function of the spleen. So the red pulp is able for the red blood cell, but not only for the red blood cells, also for other type of cells, to have a slow circulation with a double check of the age and physiology of the cells, in particular for the red blood cells. And the red blood cells may again re-enter the circulation only if they are healthy and relatively young, and so elastic to pass very narrow spaces and to have the cord and come back to the circulation. And there are a lot of very recent data on the mechanism and also the cellular and molecular mechanism of these that are very different from what we learned in the past, but I don't have time to enter this type of details. So let's summarize the main function of the spleens that are the immunological functions, and we can today forget this part because it's not relevant for the hypersplenism in thalassemia, but more specifically the pooling also of, let's say, white cells that are very important for innate and immunity and for all the other part of immunity. But at most for the red blood cell and platelets is very important, the pooling. And in case the rapid deployment of these cells. And the amount of these cells are a lot. In humans, the amount of red blood cells that may be pooled in the spleen is something that may be around 20–30% of the total number of circulating red blood cell in physiological condition. And then there is the cooling, the pitting. Sorry, the pitting is another physiological function of the spleen. That is the removal of solid particles from red blood cell, allowing the red blood cell to re-enter the circulation after the pitting. Whereas the cooling is the destruction, stopping and destruction of senescent or damaged red blood cell and other type of cell like platelets or white cell. And then there is room for erythropoiesis, yes, but in physiological condition, erythropoiesis is just during the fetal life, and only in the pregnancy physiologically there is some erythropoiesis in the spleen. Otherwise, it's very important in diseases. For thalassemia is very, very important. So what is the definition of hypersplenism? And I start from, a very basic point, that is this one, that is splenomegaly and hypersplenism are not synonymous. And I have to tell this, to say that because it seems very obvious, but it's not. Even in many publications, you find some confusion of splenomegaly and hypersplenism. And so what is the difference? The splenomegaly is just a structural change that is, okay, the spleen is enlarged, and while hypersplenism is a condition, a syndrome, where splenomegaly must be in. So splenomegaly is a component of hypersplenism ever. So we do have so many different conditions and diseases, so many types of splenomegaly we do, but luckily we don't have so many hypersplenism conditions, just in a few diseases we do have. So hypersplenism means to have splenomegaly, yes, and then what? Peripheral cytopenias. At least one of the lineages must have cytopenias. That means what? Less than normal, or better than less than normal, less than the normal level for that individual that we are considering, because in thalassemia, in example, the, let's say, normal threshold for the 3 series are not so perfectly normal as in general population. Third point, the bone marrow must be normal or hyperactive, as in case of thalassemia. So when the bone marrow is not normal, we cannot talk about hypersplenism. So for thalassemia is ever this, obviously, and this is the third point. And then the fourth is the clinical medical reasoning, that is the exclusion of other causes of cytopenias. That is the list to say hypersplenism, and only this, not to confuse to splenomegaly. And the difference is not just semantic, it's very important from the practical point of view, because generally speaking, splenomegaly is reversible if we found the causes. Hypersplenism may be reversible, but may be also irreversible. So we have to distinguish this. And then in the old definition of hypersplenism, there are also another point that was response to splenectomy. But this was in the past, when splenectomy was used a lot, or was an indication for severe form of thalassemia. That is not today. So we can forget the response to splenectomy. We have to try to avoid at the best splenectomy. But even today, if we go to the thesaurus of PubMed, of the National Library of Medicine, today we found in the definition of hypersplenism the potential for reversal by splenectomy that we should forget. This is all time we should forget what we know today. So this is the definition. So let's go to the pathophysiology of hypersplenism. In thalassemia, obviously, that is what we should have in mind: two aspects that are the main one, that is the pooling and the destruction, that are in thalassemia also mild form or moderate form of thalassemia, or severe form of thalassemia perfectly compensated. We do have more pooling and more destruction than normal, obviously, because the red blood cell recycling is higher than normal, because even when we transfuse perfectly, we give red blood cell that do have a half-life that is more than the normal one. So obviously, we should have more pooling and more destruction. Hypersplenism is when the level of pooling and destruction is pathological, very high. And there is then also a third component that may be irrelevant, may be mild, may be moderate, may be severe in thalassemia, that is the spleen erythropoiesis. So the spleen may have, obviously, again, if we go to the pathology and see any spleen removed by a thalassemic patient, we found some sign of erythropoiesis. But what is important is if this erythropoiesis is huge or not. And as we said, in physiology, the erythropoiesis of the spleen is limited to 6 months of fetal life, and then close to nothing else. In thalassemia, here you have an example. There is also you may have also a huge focal erythropoiesis that is in the spleen. As you see in this spleen that has the anatomy is fully deformed by this very large mass of focal erythropoiesis that is the equivalent of what we see in many other sites of the body in case of masses of extramedullary erythropoiesis. So these are the components of the pathophysiology. What we know about the relevance. Well, if we go to browse the literature searching for scientific evidence, in general on hypersplenism, we see thousands of publications on many diseases, obviously, and you see here that the first two that appear, the most recent one, are on a type of splenomegaly and hypersplenism that is the cirrhosis and portal hypertension that is very important in general medicine. But if you look at the number of trials and randomized controlled trial, you see that the number is very, very limited. That is in general. And for thalassemia, what? Even more, because you see that the number of papers that focus on hypersplenism is very limited, and you see zero randomized controlled trials. So we cannot discuss about evidence-based aspect. I will continue and end my presentation with simply my opinion and a summary of the opinion of the others on this topic. So opinion number one, very simple. That is, if we know that thalassemia are very heterogeneous in terms of severity. And so for hypersplenism, the risk of hypersplenism is is only for the severe form of thalassemia, thalassemia major and severe form, moderate form of thalassemia intermediate. For mild form, there is no risk of a trend to hypersplenism, and this is very simple. Opinion number two, that is the risk of hypersplenism is inversely related to the quality of the blood we obtain and transfuse. So if we, since the beginning, may use in transfusion-dependent patient ideal blood in terms of quality and ideal transfusion and transfusional schemes in terms of pre-transfusion hemoglobin, post-transfusion hemoglobin, and monitoring, the risk of hypersplenism is close to zero. At the opposite, if we don't have blood or the quality of the blood is poor or very poor, the risk of hypersplenism is very, very high or is low, that is for opinion number three. Early start is key for preventing or treating hypersplenism. So in time, if we start early in prevention and changing things that we know that are important for the physiopathology, as we said, we may have a reversal of initial or mild form of hypersplenism. And or if we use treatment because prevention is not in and the hypersplenism is there, and we use treatment, if we are early, we may prevent. If we are late, we may be in the irreversible phase of hypersplenism, and there is no way to reverse. So for prevention, as we said, is very simple. That is, here is the slide that summarizes the ideal world. That is to have a blood that is available, and what is important for hypersplenism, available blood and high quality. And what is important in transfusing this blood, that to be fresh, because obviously the age of the blood transfusion we give to the patient is very important, because if we give senior blood units, what happened? That the work for the spleen will be by far more and more, and the pulling will be more and more, and the destruction will be more and more. If we use very young blood is the opposite. And then that the appropriate scheme, because to inhibit the pathophysiology of thalassemia and also the pathophysiology of hypersplenism is important. The key point is ever the same, that is to have a pre-transfusion hemoglobin that is more than 9.5, something around that. The ideal is a personalized, individualized level for each patient, but roughly speaking is that. And also to reach a post-transfusion hemoglobin that is significant, something around this, not too much, but something around this, to have at least for a few days a significant inhibition of the expansion of bone marrow and erythropoiesis. And this may be done. Obviously, we have been lucky because it has been possible for us in Italy to apply these schemes since very early in improving the treatment for thalassemia patients. And this is the effect on splenectomy. This has been a very important result. We published this many years ago. You see on a large cohort of thalassemia patients in Italy, you see that for birth cohort of the 60s and the 70s, it was close to impossible to prevent splenectomy. So hypersplenism was very, very common, and or also splenectomy was just an indication to improve the care. Then when we saw how many long-term negative consequences are bound to splenectomy, we tried to avoid, and with good transfusion, it's possible to prevent splenectomy close to at least to 90%, if not 100%. Well, and then to close, if an hypersplenism is there, how to manage? Again, if we go to, in the literature, we have a lot on splenectomy, but you see that there are a few randomized controlled trials, and most of these are in comparison of different approach to splenectomy. So again, I cannot speak with evidence base. I have to refer you opinions. And so we said about prevention of hypersplenism. An important point is to monitor spleen size and function. That is very simple. So what's to do? Simply the physical examination, well done, very careful, with recording what we observe, and then also going to symptoms, because when the spleen size is large, it may cause symptoms that are due, one, to the stomach, that is, the stomach has less room to expand after meals and or during physical activity. So symptoms may be symptoms of bound to meals, and also in running, pain during running, or during fast walking. But to assess the site is very easy to go and use simply ultrasound. CT scan and MRI may be useful in special cases, but ultrasound is enough. Obviously, the best is to have the two sections and or to calculate also the volume of the spleen, because the anatomy of the spleen may be different in different individuals, and also in thalassemia patient may be different. So it's better to have both and to calculate the volume of the spleen. And the CT assessment is useful if you want to go in depth in details, but for normal routine, the ultrasound is enough. And is enough to control on time longitudinally on the patient if the spleen is the same, if the spleen dimension is lowering, improving, or is worsening with the progression to splenomegaly and possibly to hypersplenism. And then obviously the monitor must include the function. So for the function, it's enough just to look at the blood test simply to the level of white blood cell and platelets, and not just looking at the normal threshold, but the previous threshold levels of the individual patient. So the longitudinal follow-up is very important. And for red blood cell, Obviously, in non-transfusion dependent patient, the total hemoglobin is enough. Also, the reticulocyte level may be useful. For transfusion-dependent patient, the key point is to calculate the percentage of hemoglobin fall and/or the blood requirement. And for these, till today, the seminal work of this wonderful doctor, that is Bernadette Motel, is still up to date for today. You see this paper of, let's say, close to 50 years ago, but is the key, that is, before splenectomy, where you have hypersplenism, you have a fall that is of the hemoglobin that is faster than normal. After splenectomy, you improve these, and this is very true. And the best reference for comparison is to have the blood consumption, the blood requirement, and the best is to have the reference of the splenectomized patient, splenectomized without complication, not having alloimmunization or other complication, and then using these as a reference for comparing your individual patient where you want to know, oh, okay, there is an overconsumption that is significant, yes or no. And this is what happened with the splenectomy. Obviously, you can go down to the normal level for a splenectomized patient. This is just one of our cases of the past. You see, many years ago when we were used to splenectomize, unfortunately, most of our patients. You see a rise in blood requirement, a rise in hemoglobin fall, and then after splenectomy, coming back to ideal values. So we can skip these and to go, if you go to the, in example, to the TIF guidelines for TDT, you find just a few words on splenectomy. You find just in a chapter some wording that is a very good summary, where you find just that what we were saying, that is with modern chelation, transfusion and chelation regimen, seldom splenectomy is needed. And but in case of splenectomy, we should consider, in case of hypersplenism, we should consider, instead of splenectomy, other approaches. There are three. There are also other, but are not relevant. Three that are hypertransfusion, to give a period of hypertransfusion, to give hydroxyurea, to give thalidomide. Well, again, I cannot tell you nothing evidence-based on this because we don't have a randomized controlled trial at all on these three approaches, but we have data that say that hypertransfusion, if hypersplenism is not irreversible, may work well. Obviously, which level of hypertransfusion to have a pre-transfusion hemoglobin of at least 10.5, this, and to do this at least for 6 months. Is nothing to do this for hypersplenism, is nothing to do this for a couple of times of a transfusional event. We should go on for some months to have a significant reduction of function and dimension of the spleen. And then what's about, for hydroxyurea, there are many publications, but if you browse in details, you cannot find nothing special. So hydroxyurea doesn't seem to be so useful in trying to reverse hypersplenism. And so we do not use. We tried in the past in some patients, in difficult cases, we didn't find any important efficacy, we don't use. It's different for thalidomide. Again, in thalidomide, you have individual cases reported and or a small series with an effect that is relatively important. You see the effect here in 3 cases of using thalidomide for a period. You see the effect on the total hemoglobin, on the platelets, on the spleen size. And you have other papers, but we can go on and go to the end. for splenectomy. So if everything of the, obviously for thalidomide, what is the point? The thalidomide may be effective or very effective in thalassemia in rising the hemoglobin, improving the anemia, etc. But the use on long term is problematic. And TIFIS now is working a lot on this. We hope to produce soon many useful opinions and/or studies on thalidomide in thalassemia. For hypersplenism, using thalidomide for a relatively short period, like 3 months, may be interesting. If everything of these is fail, I'm going to the end. If everything of these fail, we can consider splenectomy, but only after a careful risk-benefit weighting. That is, and is not a problem of waiting about the procedure for splenectomy, because it's very clear you have the literature that is full of different procedures, but for thalassemia, a full splenectomy is needed, laparoscopic also with the large size of splenectomy in good surgical hands is good. And so the classical surgery laparoscopic approach is very good. There is no way, if not for research, to other approaches. We tried also in the past many years ago, but the other approaches are not so safe and effective. And then last point, the most important one, is to consider the long-term effect of splenectomy. That is important because obviously in thalassemia major, we can have benefits like red cell survival improved, blood requirement, and also for the iron overload, a better balance. But the risk on long term are a small but lasting for the life risk of severe overwhelming post-splenectomy infections that may be lethal. We do have a rise of thromboembolism that is very high. The rise of the risk of thromboembolism is very high. And the trend to pulmonary hypertension is also important. And for non-transfusion dependent patient, the same. That is a rise of hemoglobin. Even if the rise on hemoglobin, you cannot expect to do a splenectomy in a patient with an anti-DT that has an hemoglobin of 6. And you cannot search for having an hemoglobin of 10, 12, 14. You will not have. The hemoglobin will come back to the basic hemoglobin of the case and the severity you had around the diagnosis. So it's not so important, the rise in hemoglobin. Trend to transfusion dependence, obviously, you lower the risk and you lower the iron overload, but the risks are exactly the same. So that is the summary. And so in case of splenectomy, we have to set a full preparation before the surgery, during the surgery period, the post-surgery, and also for long-term follow-up. But this is another topic. Sorry to haven't taken more than the planned time for my presentation. Thanks.
Thank you, Professor Piga, for that very concise discussion on hypersplenism as well as splenectomy. And thank you for those introductory slides as well on splenomegaly, the mechanistic pathways as well. So now we will take all the questions at the end. So now I would like to request Dr. Amita Mahajan and to discuss on the Indian on the practical aspects of managing such children in India, and how would we, how does she do it in her practice? Over to you, ma'am.
Thank you, Dr. Neeta, Mrs. Tuli, and Dr. Michael. It's really a pleasure to be part of this webinar. Difficult to follow Dr. Antonio's presentation, but I will try and put some of the Indian perspective in this and share, what are our logistic challenges in our country. Are my slides visible?
Yes, ma'am.
So just a brief outline, and as the topic is similar, but perhaps the focus may be a little different, with just to understand hypersplenism a bit more and prevention, which is really the cornerstone of, of today's webinar. And hopefully we will come to a point even in India where splenectomy would be as rare as it is in Dr. Piga's. For some of us, we've not done splenectomy for many years. And I did one very recently. I was kind of forced to do, but discuss a little bit about the medical management and how, what are the options available to us to avert splenectomy in the current era and in our setting. We know that splenomegaly results from chronic premature hemolysis of circulating red cells and splenic extramedullary hematopoiesis. 80% of the damaged red cells are removed extravascularly by macrophages, which are largely present in the spleen. Dr. Piga has nicely explained the definition of hypersplenism, and I'll just allude to the situation of occult hypersplenism, where in a steady state there is splenomegaly, but no cytopenia owing to the compensatory increased bone marrow hematopoiesis. But when there is a stress like infection or some other medication which may suppress the bone marrow, the cytopenia suddenly becomes evident. And if we are, following these patients carefully, this is something that we can predict to an extent by the splenic volume, but sometimes it does take us by surprise that this is a patient who never had low counts, and why are the counts suddenly dropped. So what are the challenges that with the onset of massive splenomegaly, and Dr. Piga again alluded to that massive splenomegaly is not the same as hypersplenism, but putting both of these together. So what are the challenges that we face? One is, of course, the increased transfusion requirement with a consequent increase in iron overload, and inability to maintain an optimal hemoglobin despite more frequent transfusions, with consequent impact on the quality of life and consequences of chronic anemia. It also leads to early satiety. Many of our patients will complain that they can't really have a full meal. They have to break it into small, frequent meals, and with consequent weight loss and sometimes even malnutrition. It also makes it difficult for us to give optimal chelation, because we still, in many of our patients, do rely on combination chelation. And along with defrusirox, the preferred second chelator is oral defriperone. But with cytopenia, that becomes, not possible for us and really becomes even more frightening. So that also is a stumbling block in our ability to give. So we have increased transfusion requirement, still low poor hemoglobin, still more extramedullary hematopoiesis happening, inability to oral chelation. So it just really spirals downwards, and also increased risk of infection and bleeding, especially in patients who may have chronic liver disease, secondary to even viral hepatitis and esophageal varices. So for us, at all costs, we have to make prevention of massive splenomegaly and hypersplenism one of the major treatment goals in our setting. And just idea that how much the massive splenomegaly can sequester platelets, for example. So under normal circumstances, about a third of platelets are stored in the spleen, but in hypersplenism, about 90% of the patients may be sequestered in the spleen, leading consequently to thrombocytopenia. So the prevention really is, the proportion of patients who develop hypersplenism and massive splenomegaly really depends on the underlying disease biology. So, it differs from non-transfusion dependent thalassemia versus transfusion dependent thalassemics. And whether or not, and that is the cornerstone, whether it is TDT or NTDT, is whether we are able to give them optimal management or not. It may be transfusion management, it may be other medical management in NTDT, but that is really the optimal management is really what can prevent this complication from happening. In addition, patients who have liver fibrosis or cirrhosis secondary to iron overload and indeed hepatitis C. This is another logistic challenge that we face in our country because of NAT testing not routinely available universally. There is still a lot of seroconversion for viral hepatitis happening during treatment. And in an already iron compromised liver, I think this leads faster to fibrosis and sometimes even cirrhosis, portal hypertension. So on top of the hematological reason for massive splenomegaly, we now have the hepatic cause for splenomegaly and hypersplenism. So prevention has to be a major treatment goal, both in TDT and NTDT. And with optimal management, it is unusual to see massive splenomegaly and hypersplenism, the kind of which we used to see very often in the past. But I've already outlined the logistic challenges in our setting, which may be that sometimes we are not able to maintain optimal hemoglobin in transfusion-dependent patients. There is seropositivity of viral markers which may not have been detected and treated timely. And also sometimes for NTD patients who actually really qualify to get onto a transfusion regimen, there may be denial or refusal on part of the family, either because of social or logistic constraints, to accept that treatment, leading to very massive splenomegaly in this patient. And that's why we see them more often in NTDT than in transfusion-dependent patients. Other contributing factors are under transfusion. There is to avoid transfusion, many of our NTD patients are on HbF inducers. And for those who manage an optimal response, regardless of the long-term consequences, they actually may not have massive splenomegaly. But if they are on HbF inducers with suboptimal response, most of these patients do have massive splenomegaly, chronic liver disease, and even alloimmunization, because this again leads to chronic anemia. Many of our centers are not in a position to give phenotype matched blood, even when there is alloimmunization existing. So this then adds to the undertransfusion, the extramedullary hematopoiesis, and again further complicates the issue in our setting. So to prevent this, we have no choice but to maintain optimal hemoglobin in transfusion-dependent thalassemics, close monitoring and refinement, or maybe change the decision for a non-transfusion-dependent thalassemics with onset of increasing splenomegaly. Safe blood is no longer an option. It is a moral and ethical imperative that we spare our patients from transfusion-transmitted infections and also, hepatitis B vaccine, fortunately, is now universally accepted and given, so that incidence has gone down. Optimal chelation again will help the liver fibrosis and cirrhosis, which in turn adds to the portal hypertension component. And what is essential, whether it is TDT or NTDT, is to closely monitor the patients. It may be through ultrasound, it may be just clinically, but we have to see that we are able to suppress the ineffective erythropoiesis adequately, and the splenic dimensions are one parameter that can help us assess that. So coming to management, when we are already in a situation where we are now dealing with massive splenomegaly or hypersplenism, the first thing Dr. Piga already highlighted is hypertransfusion. So we do explain to the patients that yes, you already have an increased transfusion requirement, but to try, and it may sound paradoxical, but to try and reverse the tide, I may have to transfuse you over even more aggressively over the next few months to reduce the splenic dimension. This, of course, has to go in tandem with optimization of chelation because of the increased transfusion. And in some patients, especially if we have picked massive splenomegaly before the onset of hypersplenism, we may be able to reverse the splenic size. And in most transfusion-dependent patients, this does work to a significant extent. Dr. Piga again highlighted these medical options. Hydroxyurea, we know, induces fetal hemoglobin, but that is not the complete story. Through many other molecular pathways, it can improve hemoglobin and suppress ineffective erythropoiesis. And especially in NTDT patients, it is a very helpful inject for us to prevent massive splenomegaly, and sometimes if they have not had it in the past, to even reverse the massive splenomegaly. and it can lead to increase in hemoglobin, reduction in ineffective erythropoiesis. In fact, we do use it when we are monitoring the TDT patients and we see that spleen size is increasing. We do use it for a few months to see if we can reverse. And in a few of my patients, I have been able to reverse the splenic size, and things have gone back on track. Thalidomide, again, there is evidence it is an anti-inflammatory, anti-angiogenic, and immunomodulatory drug. It again induces fetal hemoglobin and erythropoiesis, but it also influences angiogenesis and neovascularization that contribute to the massive splenomegaly and hypersplenism. Thrombocytopenia is actually a known side effect of thalidomide, but in this setting, and if it is effective in that patient, it actually leads to an increase in the platelet count. And it is especially useful if there is concurrent alloimmunization happening because for its immunomodulatory effect. And in fact, that is where the setting where thalidomide was first used anecdotally, that it can help both the alloimmunization and also reverse the hypersplenism to an extent. Ruxolitinib, anecdotal case reports, but it was really the truth study. This was a phase 2 trial of JAK2 inhibitor ruxolitinib, which its primary endpoint was to reduce the hemoglobin or improve the hemoglobin and reduce the transfusion requirement. The study actually did not meet its primary endpoint, but virtually every patient enrolled in the study had a reduction in its splenomegaly. And there is also a parallel from myelofibrosis, a condition where ruxolitinib is routinely used. And that's why it was anecdotally, it has been tried. And in various case series and individual case reports, it seems to reduce splenic volume from about 9% to 67%. This was a study in which 10 patients were put on ruxolitinib and 9 had a reduction in splenic volume, and in many of them, the hypersplenism was reversed. This is our own small experience. We've got more patients on this drug now. They met the absolute criteria for splenectomy, which we were very loath to do. So we gave them a trial of ruxolitinib, which reduction in 2 were NTDT, 2 were TDT. And subsequently, when we were really stuck, we do give a trial of ruxolitinib for about 6 months or so. Splenectomy, it is just our every effort to really try and avoid this. I think in an ideal world, we should not be even discussing this, but it is a reality that we have to deal with this. And the complications of splenectomy also, I think most of us working in the low middle income countries, we have personally encountered. So it is recommended in patients when transfusion requirement exceeds certain thresholds, but I think hardly any of us would do it for this indication. It is absolutely contraindicated in very young children. And again, I think most of us would perhaps not consider this in children at all and only consider it in adulthood, where we have no choice. But yes, in older teenager and adolescent, sometimes we have to consider this. It has to be planned meticulously. It has to be an elective procedure with a lot of adequate counseling, with trial of medical measures before we resort to this. And if we absolutely have to do it, it should be done by laparoscopic route with all its beneficial effects and rapid recovery. This is Dr. Piga's slide from his own publication, again just highlighting that how the need for splenectomy has gone down in consecutive eras. The perioperative management, after we have discussed or kind of exhausted our medical options, the hypertransfusion regimen, trial of thalidomide, hydroxyurea, and ruxolitinib, if we have access to it, is that we have to extensively counsel the patient before we embark on this, because they must understand that they will have to have access to urgent medical attention at all times following this procedure. So if we have reached this point because optimal management was not possible, then I think we have to think twice again, because is he going to have optimal urgent medical attention following the splenectomy. But to minimize the risk, we have to offer optimal immunization 3 to 4 weeks prior and at least 2 weeks prior, because the peak antibody production after pneumococcal vaccine is between 9 to 12 days. Perioperative antibiotics must be given, and ideally lifelong penicillin prophylaxis should be given. The vaccinations we give are for pneumococcal, meningococcal, and H influenza. It should be at all, it should be an elective procedure. This kind of patient should not end up with an emergency splenectomy, and it should be completed 14 days before surgery at all costs, but ideally more than 4 weeks. Following splenectomy, patients should in addition receive influenza vaccine. I'd just like to highlight which pneumococcal vaccines to give. So it is currently recommended that both the conjugate PCV13 vaccine and the older polysaccharide 23-valent vaccines should be given. And it should be the conjugate vaccine to be given earlier, followed by the polysaccharide vaccine, because the other way around does not work. The PCV13 should work as a primer, followed by the 23-valent vaccine, which sort of triggers the memory cells and broadens the spectrum. For countries that are using the novel PCV20 vaccine, we do not need to give the polysaccharide vaccine because the PCV20 conjugate vaccine has a broad enough spectrum. So just this point to remember. In terms of complications, infection or overwhelming post-splenectomy sepsis is our most dreaded complication. But the 3 other areas I'd briefly like to highlight are hypercoagulability, increased iron overload in the other organs, and pulmonary hypertension. We know that spleen has a very crucial function in immune defense as a phagocytic filter for blood-borne microorganisms, particularly the encapsulated bacteria, and it also produces antibodies. Loss of memory B cells in the splenic tissue and marginal zone monocytes increases the risk of OPSI by about 30-fold. And these capsulated organisms, the pneumococcus, meningococcus, and haemophilus, are the most, often culprits. But because we do give optimal prophylaxis to these patients, other staff are actually becoming more, more prominent in recent series. So 30 to 50 times higher risk of infection, and because all patients are immunized, because they are on prophylaxis, it is now the gram-negative bacteria and staph along with some other pathogens. OPSI can be potentially fatal and does have a high mortality rate if immediate urgent medical attention is not given. And for countries like ours where malaria is still endemic, even this can be much more severe in asplenic people with increased risk of mortality. So this is another thing for us to watch out for. So if we were to embark, I think we should give a dose of intravenous antibiotics for all patients to have with them, where in case of a febrile illness, even if they can't be assessed, they are able to get that first dose of antibiotic very promptly at a nearby medical facility before they can reach us. Venous thrombolism risk is increased, and the primary reason is that the abnormalities of platelets and red cells, they are the key factors leading to a hypercoagulable state. And now that they are in free circulation and not being scavenged by the spleen, these increase the risk of venous thrombolism. Splenectomized NTD patients have a much higher risk of venous thrombolism and silent infarcts, and the median time to develop this complication is many years following splenectomy. So perioperative thromboprophylaxis can help us avoid portal venous thrombosis and immediate deep venous thrombosis, but we must recommend low-dose aspirin to all these patients. Pulmonary hypertension is also, it's a consequence of multiple factors, including microthrombi, but also seen more frequently in NTDT. But if we look for it, we do see it in TTT patients as well. Iron overload is another thing that we've encountered, that, usually a patient who ends up with splenectomy also has a bad liver. So it kind of suboptimal management brings us to this, this eventuality. And sometimes we have seen that following splenectomy, because all the, extra iron is now landing in the liver, there can be, acute hepatic decompensated liver failure. So we know that there are higher serum levels of non-transferrin bound iron in splenectomized patient, which is really the more toxic form of iron, and increased iron accumulation in liver, heart, and other organs has been documented systematically in post-splenectomy patients. Partial splenectomy is no longer offered because of regrowth of residual splenic tissue warranting completion splenectomy. So this is no longer an option. Splenic irradiation, very low dose, was given in the past, but results were equivocal. Again, it is no longer offered as a therapeutic option. RFA it's an easy thing to do, and sometimes it can buy us time, help us to stabilize the patient, but almost always the splenic tissue will regrow. It is a relatively, this is just a slide to show. On the top is the massive splenomegaly, and the bottom pictures C and D show the remaining splenic tissue after RFA. It is relatively safe, but it is not a permanent solution. So if we feel that other modalities may help us reverse the hypersplenism, then this can give us a transient relief. And similarly, selective splenic artery embolization could be considered where they have access to this specialized intervention, but it can have its own complications, which may sometimes lead to a need for immediate splenectomy. So if we embark on this procedure, we have to be prepared to take the patient to splenectomy if any of these complications emerge. So I'd just like to end by a patient that, after many years, I had to resort to splenectomy 2 weeks ago. A 30-year-old young lady who transferred to our center 18 months ago. She already had hypersplenism with marked cytopenias, and platelets were around 50 to 60,000. The ANC was consistently less than 1,000. She also, in addition, had marked iron overload and alloimmunization requiring blood transfusion weekly, but we could still not get her a pre-transfusion hemoglobin of even 7. So we tried hypertension, we could not do it. She had hepatitis C in the past with quite significant liver fibrosis. So we tried phenotype matched blood. We tried to manage the immunization with steroids with some response, but not complete response. I added L-Trombopac to empirically to enhance the platelet count. And surprisingly, there was a good response. This was just a kind of a shot in the dark, but at least it helped me stabilize her platelets. We did give her a trial of ruxolitinib, and in her case, there was no response. Very cautiously, because she was already cytopenic, we gingerly gave her a trial of hydroxyurea, which again showed no response, and finally thalidomide, which she continues to be on. Even required intermittent GCSF because the ANC touching 500 on a few occasions. And at that time, it became evident to us that splenectomy is inevitable. So after a lot of counseling, we immunized her. Chelation we optimized as best as we can. We could not use deferriprone, but the other two she took consistently with actually a significant decline in her serum ferritin. Fibroscan also showed with aggressive chelation some reduction in her fibrosis. Because she had kind of chronic liver disease from the hepatitis C, we looked at her upper GI endoscopy about varices. She had grade 1 varices, but we felt it was safe to go ahead. We optimized her lungs by incentive spirometry and a lot of counseling, because this is a surgery we had not done for a long time. She underwent splenectomy 2 weeks ago laparoscopically, and a 2.5 kg spleen was removed. These are her counts as of yesterday. So the ANC, so at least for now, she seems to have, our biggest worry was the neutropenia and the thrombocytopenia. She's on aspirin, penicillin V, and she's now on triple chelation because we are able to give her deferriprone. So to summarize, massive splenomegaly and hypersplenism are, if not always, at least largely preventable by optimal management and monitoring. And usually, ideally, we should not have to deal with us, but it will remain, especially in NTDT. Some of them, even despite optimal management, we may have to deal with us. Medical measures may avert splenectomy in some cases, and inevitable, if inevitable, proper preparation, immunization, and counseling are very essential. And prophylaxis and prompt medical attention in case of fever and infection cannot be emphasized, too much. They need to kind of think of this always and have a dose of antibiotic like we have for our neutropenic fever patients with them always. Thank you so much, and I'd be happy to take any questions.
Yes, ma'am. So we have a lot of questions in the chat box. I think we'll do the panel first, and then because that again are similar questions as well. So I would request Dr. Aditi Tulsian to join now. And Dr. Aditi is a second-year fellow in pediatric hematology oncology at our center. And Dr. Aditi will be discussing this focused discussion on three case scenarios, which are similar to the ones that you showed, the patient that you shared. So we'll discuss a little bit on prevention, just to reiterate some of the facts, and then we'll go to the management aspects. So Dr. Aditi, over to you.
Good evening, everyone. I will be discussing three cases. So starting with the first case, it is of 13-year-old boy who was diagnosed as a case of HBe beta thalassemia at an age of 2 years. He received his first transfusion at 7 years. Till then, he was a anti-DT phenotype. But after that, after starting transfusion, he required a regular transfusion. And since February 2024, in view of poor growth. Since then, he has been on regular transfusions. He is requiring 2 units of PRBCs every 4 weeks and maintaining a pre-transfusion hemoglobin of 9 to 10 gram per deciliter. So on examination, he had hemolytic phases, a large liver that was 4 centimeter below the right costal margin, and spleen was quite large, 10 centimeter below the left costal margin. And he also had growth failure. The growth centile was 10.2 height for age. So, ma'am will be discussing the panels.
So we'll start with the questions. For questions. So this is somebody this is again something which is very similar, very frequently encountered in our studies, that many patients are diagnosed as non-transfusion dependent, but they are not followed up adequately as an NTDT patient should be followed up. So by the time they present at the age of 10 years or so, initial 5-10 years goes off without any issues. By then, by the time the growth issues, the puberty sets in, or the massive spleen sets in, that's when they get referred. So I'll start with Dr. Piga. So how would you, when a patient comes, again, there are patients who are joined in this call. So how, in today's day and age, when a patient is presenting it to you at the age of 2 years with a hemoglobin of 5 or 4, etc., how would you classify as NTDT straight away, or do you wait for transfusion, wait for the hemoglobin to drop again and see? How do you decide what phenotype it is, TDT or NTDT?
Well, if the total hemoglobin is 4-5, it's very easy, because I have just to exclude that hemoglobin is lower also for some acute reason like an infection or something else. If not, I can predict easily that unfortunately that patient without having transfusion will have a severe progression of a thalassemia intermedia. So if I can, that is safe blood available, I will start the transfusion. That's all. If I can't, obviously, I will try to do my best. And the previous presentation was very nice in describing what can be done if we are not in the ideal world from the blood point of view. If we are talking about a very different hemoglobin, that is, today we have, we can say, scientific evidence for this from large studies that if the hemoglobin is above 10 in a patient with NTDT, we know that the prognosis is good, that the risk of complication is low or very low or nothing, depending on the type of, and the same is for the trend to iron overload, very low or nothing. So, but within these two extreme, 4, 5 of hemoglobin you said as an example, and 10, there are the majority of patients with thalassemia intermediate, because at diagnosis we see something around 8, 7, and then we are around, so more we are in the middle, more is difficult to balance. So the individual assessment that is adding also the genotyping, that is for the hemoglobin genes, that is beta, alpha, gamma mutation, but also other aspects may help, but is not easy to predict fully the phenotype if the patient is in the middle as the degree of anemia. So some follow-up, let's say 1 year, 2 years, no more, not to sleep quietly in the follow-up, but some follow-up may be useful in the most difficult cases.
Yeah. So what I understood is that if patient is coming in like hemoglobin around like say 7 or 8, and or maybe like 6.5, 7, that range, just keep them under follow-up very closely before you just don't label them as NTDT and send them away. Keep them on follow-up and then make a decision after a year or so where they actually fall. So Dr. Amita, would you want to add to this?
I think that it's not the hemoglobin for us in terms of the indication for switching a patient from say conservative management to a transfusion dependence. It would be whether their growth is adequate. So the hemoglobin should be at least 7, but I think that's again is an absolute indication. Why should we be acceptable to have? So their growth should be adequate, and their ineffective voices should be adequately suppressed in terms of the facial dysmorphism, the hepatosplenomegaly. It should not be excessive, and most importantly, we should be having good quality of life in terms of being able to do the physical activity that a young active child would desire to do. I think in the past, at least in low middle income countries, our treatment goal has been in NTDT has been to avoid blood transfusion, whatever be the price. But I think that is now changing, that they also have a right to have a healthy body. And we know the consequences of that management later, which makes it much harder to reverse. So I think we are now much more proactive and encouraging them to transfuse, a transfusion dependent situation. And I think the acceptance is also increasing.
Thank you. So that brings us to the next question, that in NTDT, splenomegaly is almost accepted as the norm, like in the style, for example. So what is normal, as in how much of splenomegaly should we accept? Should we accept an asymptomatic splenomegaly? Should we accept a mild splenomegaly? Should we accept a splenomegaly as long as the growth is fine? So what is acceptable in NTDT setting? And in an NTDT with increasing splenomegaly, we would generally shift them to a transfusion regimen. So what is the point at which we should intervene in a non-transfusion dependent patient? Dr. Piga first and Dr. Mahajan after that.
Yes, acceptable is number one, the quality of life of the patient. If the patient is symptomatic, the splenomegaly, regardless the size, is problematic. That is the point. And obviously, if there are other signs of the hyperactive bone marrow, that is a trend to thalassemic sign, even mild, and or if the transferrin saturation is not fully normal. If the transferrin saturation is more than 60, this is an important, not once, obviously, but it's stable that high, that is more than 60, we know that that patient not only will develop on long term, after many years, maybe significant iron overload, and but also there is an important trend to the long-term complication of thalassemia. So we will not consider the splenomegaly alone. That is the point. For splenomegaly per se, if not symptomatic, is not, there is no evidence that the splenomegaly, if not enormous, is worsening the growth in terms of height. For the case you presented, I saw a height that was, the centile was very low, but I didn't see the parental check, so you should exclude if it's a constitutional low height, etc., because that is very important.
Yes, thank you. Dr. Mahajan?
Yeah, so I agree to, usually it goes together. If it's a splenomegaly, so at diagnosis, maybe it is a child who's 7 or 8. And if we are going to try some non-transfusion based management like hydroxyurea, then we would, the exact size, we would just see or how much regression happens. And usually if they're good responders, there is significant regression over the next 6 months or so. But after that, if there is an increase, there's no absolute size, but if there is an increasing size, it usually goes with a suboptimal hemoglobin, more in, the faces getting dysmorph, or inferior quality of life. And I think those just, together, one would decide whether now is the time to put. And again, it's something that is, we may try to increase the dose of hydroxyurea, but it's definitely an increasing splenomegaly is an indication for intervention, whether it will be some more aggressive medical management or a transfusion regimen, ideally a transfusion regimen. But again, it takes us time to convince a family who has been labeled as, NTDT. So I wish there, I don't know whether it is right to switch back to intermedia. Maybe it is a better terminology, which gives them, because once we label them as NTDT, it is in their head that, we are NTDT, so we are not to get transfusion. So I think we have to bring it up, and over the next 6 months, we get more time to observe what is happening with the spleen.
Yeah, very true. And so one question to you, Dr. Mahajan, regarding E-betas. So E-beta again is highly subjective management. It's not like a bookish management for every patient. So typically when you have an E-beta kid presenting around 2 years to you, how do you counsel them regarding transfusion, the requirement of transfusion later in
So
life?
I think E-beta, because, the oxygen dissociation curve for the E component is to the right, and they do get more tissue oxygen. So even E disease and E beta, many of them are okay, but some of them do require transfusion requirements. So again, a period of monitoring and observation is required. And they, many of them may not. So for them, it is even more important that we don't base our decision making on the hemoglobin alone, because even at a relatively lower hemoglobin, they may actually manage good growth and everything and not massive splenomegaly. And again, if one were to consider splenectomy in NTDT, I mean, we cannot predict who will respond how much, but it is the E beta group that may actually respond better in terms of post-splenectomy improvement in hemoglobin. Not that we would recommend it to them, but I think if we were to push to make that call, the others will come back to their baseline, I think, after some period. But E beta may actually benefit, and that's why, at least in the eastern part of our country, splenectomy for E beta is still happening, because they do see better responses than we see in other patients.
Thank you. So I think we'll go to the second case, a slightly more complicated one. Dr. Aditi?
So this is a case of 13-year-old female who was initially diagnosed as homozygous beta thalassemia and was managed initially as non-transfusion dependent thalassemia. She was not getting very frequent transfusion, but to us she presented 3 years ago, and we had shifted her on regular transfusion to maintain a pre-transfusion hemoglobin of 8 to 9 gram per deciliter. So she also had growth faltering and had hemolytic phases. Liver was 6 centimeter and spleen was 8 centimeter below the left costal margin. And we also did a T2 star MRI for the child, which showed normal myocardiac iron overload, but she had severe uh, hepatic iron overload that was 1.23 millisecond. And she was on regular transfusions, but she also had few further issues. In due course she was alloimmunized, and there was a kel antibody found, and she was managed with a short course of steroids, and during this time she had a higher transfusion requirement also. She had hepatic HCV reactivation and had hepatic dysfunction. She was on dual iron chelators, defruxirox and defrupiron, to the maximum tolerable dose, but the spleen size always remained the same. There was no improvement in the size of the spleen, and the annual PRBC transfusion requirement was also very high. That was around 500 ml per kg per year for the child.
So again, not so uncommon scenario. NTDT patient infrequently transfused. We switched them to a transfusion regimen because of growth issues and big spleen. NTDT kids are more prevalent, more prone to have allosensitization. So they end up with an antibody. We have been treating. Transfusion requirements have not come down. And despite trying all the transfusion efforts, the spleen is still the same. It's not really helping, and child is very cachexic, like you mentioned in the in your slide, Dr. Amita. So I'll start with Dr. Piga. When a transfusion dependent child presents with a splenomegaly which is progressively increasing, and what are all the considerations that we should keep, and how can we reverse? I think partially answered by you already. If there anything you want to highlight, Dr. Piga?
Well, this case is not splenomegaly. I didn't see that you didn't mention the platelets and white cell, but I guess that is not just simply splenomegaly. It's true that when there is a lot of hemolysis, maybe that the hypersplenism is not there, but the splenomegaly is there. But what is important in this patient are other fact that you said, that is the height of this patient is really very pathological, and the face and the thalassemic features are very, very severe. So unfortunately, I think that there is no way to have a full reversal of this. So, and if the alloimmunization is treated properly, that is, it's possible to give a regular transfusion, it's a fact. But if this is not happening, that is difficult to transfuse, to have a patient like this with scarce transfusion and going on will be a disaster. So survival and quality of life will be a disaster. So in certain cases of severe immunization, we switched to stem cell transplantation. Even relatively high risk stem cell transplantation, like haploidentical, because the balance of benefit and risk is very shift, because the prognosis is so severe that it's better to go, if possible, if feasible, to a stem cell transplantation and to try to solve at the same time the hypersplenism and obviously the genetic defect than to have a very bad and short life.
So if you are taking up for transplant, would you do splenectomy prior before taking them up? Because the transfusion requirements and the course during transplant is going to be really tough with this big spleen.
That is, normally this is done and recommended also from our colleagues that do transplant. It depends on the individual case. If there is room for, if the case is not so severe as regard hypersplenism and splenomegaly, I would not, because after a successful transplant, you have a very important improvement. If not, I would go to splenectomy or to have some treatment with rituximab before the transplant could be an idea, because in some cases there are experience. We had also some patient that after rituximab went to transplantation in a better condition.
Yeah. Dr. Amita, anything to add?
No, it's just that, this case would frighten a transplantologist with the liver dysfunction for VOD and the spleen. And if we do splenectomy, then the chance of sepsis during transplant is even higher. So this is like a nightmare scenario. I think I'd target the aluminization first, and see, like he said, with rituximab, maybe start thalidomide, because that can help, the hemoglobin, that can maybe help us with the aluminization to an extent that may reduce the sphenic size to something. And if the child does not have severe cytopenia, that may be an option to give rituximab and thalidomide and just see. But it'll take a lot of courage for a transplantologist, and yes, with guarded outcome. But yes, that.
And Aditi? Yes, I think that was the next part of the question. So in an alloimmunized patient where we have tried phenotype matched blood, we have tried steroids, rituximab, yes, that is something which is being planned. Thalidomide have already added, not really helping, and especially with the liver dysfunction, thalidomide also you can't give beyond a point. Chelation also has to be interrupted multiple times. So it's becoming a really challenging scenario. So we even considered splenectomy. She got admitted for splenectomy, but then her pre-anesthesia clearance didn't come through because she had liver dysfunction. Her PT-INRs were prolonged at that point of time. So ultimately, we did not do the splenectomy as well. So it's kind of a very difficult scenario. She's back on transfusions. So we started a trial of ruxolitinib for her. She tried for a month, was okay, but the only thing is it's so costly, she couldn't manage the rest of it. Yeah. So I think these are the options, right? In an aluminized patient with a very high transfusion burden, options for treating would be, like you mentioned, rituximab probably can be added to this existing treatment.
And once, after rituximab again, because a lot of these patients have autoimmunity as well. And the allo antibody is not as easy as just kill. There is like pan allo antibody or along with auto antibody. So we do sometimes add as a thiopurine as well. So to try and get them off steroids as a steroid sparing, because
Yes, it's true that in the most severe case of immunization, we went to transplant. It's true that is a high-risk transplant.
Yeah.
Obviously, if also splenectomy
Yes, high.
was not feasible for the risk, can you imagine transplant? It's true, but this case will not survive so long with a very poor quality of life. So if it's possible to try to solve both problems at the same time could be very risky, but the only chance, I guess.
Thank you. Yeah, so I think another question, and then we discuss a bit about splenectomy at the end. So, Dr. Aditi, last question.
Yes. Yeah. So this is a 8-year-old female who was diagnosed as beta thalassemia major, and she was a transfusion dependent thalassemia, and she was being transfused every 3 to 4 weeks initially. However, the transfusion frequency increased to every 1 to 2 weeks, and maintaining a pre-transfusion hemoglobin to 8 to 9 gram per deciliter. She has a massive liver and spleen. The liver is 10 centimeter below the right costal margin and has a very big spleen extending below the umbilicus, and it is almost 15 centimeter from the left costal margin. And she's on dual iron chelation, deferoxin, deferiprone. But she was admitted multiple times with history of recurrent infections and cytopenias, due to which we had to withhold the iron chelation, and she was being managed regularly with transfusion support.
Yes. So again, just to highlight these things, that patient, both these kids, the second case and the third patient, would not have come like this had they been transfused well in the beginning. Like both our speakers showed the importance of early good transfusions. If that was monitored and if the spleen size was monitored early enough by the centers where it was managed, it's become so tough right now that there's hardly any options left for us. So now coming to my first question to Dr. Piga. So when we have splenomegaly with cytopenia as a part of the splenomegaly, do we follow the same guidelines for chelations, like chelation cytopenias? Do we have to adhere to the same? Because it's not marrow suppression, it's just peripheral pooling that's happening. Here we have to interrupt treatment, whatever option, like that, even Kelfer as well as for thalidomide, there are very frequent interruptions. So what do we follow the same in your practice? What else, as in, do you follow the same guidelines for that?
No, we don't, because as you said very well, it's a pooling, the point number one. And pooling is not totally reversible. In case of infection, a part of the pooled granulocytes and other cells go to the bloodstream. So we do have a more, let's say, relaxed approach. We don't use the classical threshold of 1500 for neutropenia and 400 for a gran. We say, okay, we can not to lower too much the ferritron. That is the point. And so we are more optimistic, counting on the fact that there is a very important pooling. The case is a very, very severe case. My impression is an irreversible hypersplenism. Again, as the previous or worse than the previous one. So again, the same discussion.
Yeah, and so what about platelet for chelation? What is the threshold? Do you relax it to
We
less
don't
than
use a threshold. We use, obviously, if the platelet count is very, very low, that is less than 20,000, and or if there are also some even minor hemorrhagic sign, we obviously we consider. And but otherwise, if the patient is okay and the level is so no sign, and the level is more, we are optimistic, or relatively optimistic. Obviously, the case is very, very severe, and again, a very low quality of life
Yes,
for this
very
girl,
true. Because
unfortunately.
very frequent admissions for her as well. So the next question, Dr. Mahajan. So splenectomy, currently in your practice, you said that's probably one case you have advised splenectomy after many years. What are the situation scenarios where you will advise the absolute indication for splenectomy?
I think the stated absolute indication has been this degree of cytopenia, but again, this kind of goes with everything. This is a patient who will do badly, even if we were to take them to splenectomy. I'm sure this is in parallel. There is bad iron overload, there is alloimmunization. But cytopenias is one indication where because it really compromises everything we do, and the risk of infection may be higher than that with splenectomy. So that is, but otherwise, the relative indications that we used to use in the past, like discomfort or early satiety and just the size, which is uncomfortable, those we no longer follow. And, again, ideally, we should not reach to that point. But those patients, we would still try very hard with hypertransfusion or medical management to see if we can revert. Even with the cytopenias, sometimes we do try to, we've tried even now in 4 patients and thrombopack to help us push the platelet count so we can give hydroxyurea or thalidomide, and even intermittent GCSF, that it to allow us to even do the medical management. And, quite often it does work. If, it all has to be given at the same time, the hypertransfusion the medical management, and just if we can, avoid splenectomy, because we have seen all the, in the past, portal vein thrombosis with acute deterioration of the patient, lobar pneumonia following recovery from splenectomy, all kind of various complications which we dread now to that's why we dread splenectomy. And in general, even if they've not had a catastrophic complication, the overall clinical course of the patient seems to go downhill. That maybe the iron is being dumped into the liver. Like one patient in the past, I remember, came to us after splenectomy, and his hepatic function just worsened dramatically after that, and he went into decompensated liver failure. So I think the less we are seeing this less and less, but again, the absolute indication would be cytopenias that we can't resolve with any medical management.
Exactly. And so in your patient, I had a query. So whenever you're advising, when you advise splenectomy, and do you like routinely look for, do you do an endoscopy to look for varices and prior to splenectomy? Because if there is an element of
Completely.
liver.
Like this was a girl who had hepatitis C. Her fibrosis was, on the fibro scan was just short of cirrhosis. And we thought, usually the varicose after splenectomy, as happens in portal hypertension. I mean, we did it more as just to understand what is the component of portal hypertension in this and what is the component of, ineffective erythropoiesis in this. So she had grade 1 varices, but if you were to do splenectomy in a patient with portal hypertension, usually their varicose bleed and think the risk decreases. But we just wanted to just have a basic understanding of, the massive splenomegaly, and like she had a 2.5 kilogram spleen. What component, which disease is playing.
Yeah. So Dr. Pigaf, regarding splenectomy options as well. So a lot of surgeons and even I get referrals saying that we'll do partial splenectomy. So does that really help in our scenario? Because spleen should regrow in patients who have hemolytic anemias. So how have you attempted that in any patient? And what is the usual in a scenario like this? For example, if we do splenectomy in her, to what extent can we reduce transfusion requirement? 10%, 20% or more?
Well, I had direct experience of partial splenectomy in the sense of selective arterial ligation. That is, that in the attempt to have an involution of just a part of the spleen, but without cutting surgically the capsule of the spleen. This was the difference of partial splenectomy and selective ligation of some of the arterial vessel of the spleen. But the results are not good. And there is the medical literature say very clearly that partial splenectomy in case like this one, the case you presented, is not useful because with the partial splenectomy, you obviously you have some partial result, but you have two side effects. One is that you have the capsule is not have lost its integrity, so it predisposes to spleen ruptures in case of trauma, even mild trauma. One. Second is that you have splenosis. That is, during the surgical intervention, you do have a spreading of spleen tissue in the cavity, and so you will have a dissemination of spleen tissue with the reconstitution of some, let's say, spleen anatomy that cannot be fully functional as the natural spleen because for the anatomy will not be the same. So for the function, it may be useful in lowering the risk of OPSI, that is very severe infection, but not useful for the filtering activity of the spleen. So at the end of the day, no partial splenectomy. The medical literature is very clear. It's for research and surgery is another topic, but for dealing with thalassemia, we are talking about thalassemia and caring and the best clinical management, I would say no partial splenectomy.
Thank you very much. Very, very clear statements. So next question regarding optimizing a patient if we were to send for splenectomy. I think Dr. Mahajan already discussed vaccination. She showed all the schedules. Only one query left in this is antibiotic prophylaxis. How long do we continue? So if you can quickly tell us, ma'am. You're muted.
Absolutely mandatory to give it for 2 years post-splenectomy, but ideally lifelong. So all guidelines currently state, because the risk of overwhelming post-splenectomy sepsis persists for life. It is highest in the first 2 years, but it persists for life. So I think our recommendation should be lifelong. Even a single life lost to a treatable infection is unacceptable. Some other people, as a unit policy, use 5 years or 18 years of age or 35 years, but it is very clear that ideally lifelong.
And then for Indian patients,
yeah.
what are you advising now? Do you use Pentits or do you advise some?
May I add
Yes,
something
Dr.
on this
Piga.
point?
Yeah.
That is, we ever had a different, a slightly different approach. I agree with you, but it's very clear that more important than antibiotic prophylaxis is the full awareness of the patient of the residual risk, even at a long distance from the splenectomy. So we always worked a lot on informing fully the patient, having the patient with a card with said splenectomy, having the patient aware to take with him an antibiotic ready to be taken in case of not having a doctor available immediately, in case of fever or some sign of infection, because it's very clear that the risk of fatal sepsis from capsulated bacteria, it depends on timing. So if you, after a certain time, there is very clear that an infection of this type may be fatal. If an antibiotic is started during the early phase of multiplication of capsulated bacteria in the bloodstream, that is the point, you may stop at least the severity of the infection. So we always work on that, even in the daily routine. So any splenectomized patient coming to our clinic, even after decades of splenectomy, how has been this month? For transfusion, in example, how has been this month? Oh, I had some fever. Oh, and what happened? What you did? So history, if the history is saying that the patient is not fully aware, we again discuss. And this is very powerful because the patients see that even after 30 years from splenectomy, oh, the doctors are carrying me for the risk of severe infection. So they become strong on this. They do have the antibiotic in the pocket and they do what is perfect for that. I had a very bad experience with OPSI. We have lost 3 patients for OPSI, fatal acute OPSI, after a successful bone marrow transplantation. 9 months, one case. So there was, you may say, some immunosuppression, but the other 2 were 3 years after bone marrow transplant, and the other more than 5 years, was 5 or 6 years after a successful bone marrow transplant. So I guess is a small risk, but is there. So antibiotic prophylaxis is useful, obviously in small children and for during the first period, but then is close to nothing.
Thank you very much. We were discussing regarding penitits. So because K-pen is something which is not available anymore. So what are you using in your practice? But Dr. Piga also mentioned antibiotic in the pocket. So what antibiotic are you prescribing in Italy? What do they have?
Plus clavulanic acid, simply that.
And if they have fever, do they take that, or do they take that?
We recommend if you can have fast attention from your doctor or a doctor, go. But if this it may be fast, immediate, otherwise start and then search for medical attention.
Okay, thank you. And Dr. Mahajan?
So oral pentid is available. That's what we are giving to the patient for prophylaxis. And we tell them to carry a vial of monoceftriaxone because little bit the spectrum of OPSI is changing, especially if they are, well immunized prior to that.
Yeah. Now regarding, again, another dreaded complication of splenectomy, and these are all reasons why we should not be encouraging splenectomy. So thrombosis risk, how do we follow these patients? At what platelet count are we advising aspirin? And what else can we do? Like if they have a surgery or anything else, do you add on to the thromboprophylaxis at that time, Dr. Piga?
Yes, we don't use a fixed and rigid threshold. Obviously, we have in mind, and we use, let's say, 1 million platelets count as a very raw threshold. But again, there is scientific evidence that the risk is even with lower values. So we try to personalize. If the patient had some risk of some thrombophilia even before splenectomy, we are more conservative. And obviously, we use at least aspirin ever. If the patient has no risk, we wait that is 800,000, 1 million to start. And for surgical intervention or at risk condition, obviously heparin. We give heparin as a preventive treatment for the period that is needed.
Thank you. And I think it brings us to the last question for both speakers again in emerging new therapies. So we have now access to luspatercept in our country, and now there's a lot of activity around the new drug which has been just licensed in adults. So in your practice, so we already mentioned the repurposed drug which is thalidomide. Both speakers spoke about it.
Try that person.
Please, can you mute yourself? Hello. So what are the other drugs? So have you tried luspatercept? What is the role of luspatercept in these scenarios? Dr. Viga first.
Yes, for luspatercept, a summary of spleen and luspatercept in our experience is this one, that on the average, we didn't see any significant effect in terms of improvement or worsening of the, let's say, spleen problem, let's say splenomegaly. I don't have in mind the case with hypersplenism and luspatercept in my series. I don't. We know that luspatercept may be, if the patient is responding, will be effective in improving the erythropoiesis. So if for the spleen, the component of spleen erythropoiesis is important, you may expect to have a positive result with luspatercept. That is one point. If it's not there, as regard the pooling and destruction, I guess that no significant effect will come with the luspatercept, so it will be neutral, and we didn't see any important change. It's different for the extramedullary erythropoiesis masses because in some patients there is a trend to worsen existing small masses of extramedullary erythropoiesis. In other patients, no. It's depends, it's individual. If a patient has masses and or at risk anatomically in point that are at risk of giving complication, we do not recommend to start luspatercept. This is what we do.
Dr. Mahajan?
I mean, our personal experience with this drug is very limited, but theoretically, again, it may help in some patients, depending on what is the contribution of the splenic erythropoiesis, but unrealistic to expect major changes.
Yeah. Thank you. So I think with that, we had the questions which we had planned, they are over. And I'll look at the chat for more. Yeah. So in a patient, is there a role of hydroxyurea with in TDT management?
We expressed in our two talks a position that was slightly different. I was less optimistic on a role of hydroxyurea. But again, when the component of splenomegaly and hypersplenism is spleen erythropoiesis, so that is important. I fully agree with Dr. Majan. That is, the hydroxyurea may be very useful. If the component is just pulling and destruction, I don't think that hydroxyurea may help. And in our experience, has not.
Role of aspirin, I think we already discussed that. Then there's some question on malignancy following use of thalidomide. Would you want to comment, Dr. Mahajan?
So, I mean, that is a real concern. And thalidomide, in thalassemia, I know there are patients and parents joining this webinar, so we don't want to, scare them. But there is a slightly increased risk of leukemia in patients who have hyperactive marrow disease. And we must appreciate that. And it's not like many people are having. Thalidomide is a drug which can, have good benefits in the short term in many patients, but one of our major concerns is about continuous use for many years, because in other diseases where it is used for 6 to 12 months or maybe after 2 years. And it does have properties that can trigger leukemogenic transformation. So even in multiple myeloma, which is the classic disease where this is used, after 2 years, about 2 to 3% patients will have some leukemic transformation. That may partly be because of their disease. It may have some contribution from thalidomide or its other newer versions like ponalidomide or lenalidomide. So yes, it is a concern, and that is why we don't want everybody to indiscriminately use thalidomide. We don't want for them to use it endlessly. For whatever reason, if it has to be used, it should be under very close medical supervision. So this is an area that is, I think, as hematologists, we are still navigating. We know patients can respond well to thalidomide, but these long-term concerns, they are a major issue, because in thalassemia, you have to take it endlessly year after year. So like Dr. Piga said, if you are going to give it for a trial for 6 to 12 months, it should not be a major concern. But if we want to put somebody on thalidomide, I think we are all trying to pool our data. He said already TIFF is doing major work on this to collect all the information. We are already hoping to maybe have a registry of patients so we can actually quantify how much is that risk. And then ultimately we openly and transparently discuss with the patient and, share with you, because a thalassemic patient is not like any other patient. Many of our patients know more thalassemia than I do. So I think this is like we are partners or team in treating a patient, and we openly discuss all the pros and cons with them. And, then we take a decision whether we should receive or not. But thank you for raising this important point. And I hope I have answered it clearly.
Very clear, very clear. If I can add something to this, just to underline how important is your position. And to me, there is a need to collect data, facts on this, because most of I did a review of thalidomide use in thalassemia, and India has been pioneering this use. And now the extensive use of thalidomide is starting in other countries that till up to now they didn't use. Now they are starting, countries with a lot of patients. So it's very important to also to collect facts on the safety. And so from this point of view, with TIF, we are trying to set some way to have some, let's say, fast collection on the point, obviously, of leukemias, with a very fast survey on these. And I hope you will hear from us on that. And obviously, on long term, a register would be a very powerful way to have facts on long term that will be very important for full information of the patient in taking difficult decisions.
Thank you. I think with that, we come to the end of today's session. And I would hand it over now to Mrs. Tuli she summarizes it beautifully usually at the end of the session, and for her comments. And before I'll sign out, the next session is on successful pregnancy and childbirth in thalassemia. So the next session is on 12th of February. So we'll be sending out the flyers soon. Over to you, ma'am.
Thank you, Dr. Nita, for your kind words in the beginning also, and at this point of time also. So excellent presentations by both the speakers from overseas and from India. And both the speakers have stressed upon that how the hypersplenism is preventable, and the value of the spleen, which normally sometimes, the patients do not give attention to that, and the quality of transfusion. It is, and Dr. Piga has in a very nice way, he has mentioned that what do we really mean by the quality of transfusion, which should be fresh, adequate, safe, and pre-transfusion should be absolutely, 9.5 grams. And the assessment of spleen is so important. And of course, you also mentioned about the assessment of the spleen size, how it has to be done. And by both the speakers, that ultrasound is the best option to do that. And in case of hypersplenism, the three approaches were also discussed. Just a comment on the thalidomide, which has been discussed. I'm very happy that this topic has been discussed and it has gone to the TIF level also. So my question to both the speakers at this point of time is, should we advise or continue giving thalidomide to patients, or should we break at this point of time after hearing that there were some problems, of some of the patients who used it for nearly more than 6 years and all that, or we should give thalidomide under a special, under the guidance, and the strict adherence has to be there and all that. So that's you can give the reply in the end. And then was the careful risks were discussed about that. And Dr. Amita Mahajan has very nicely mentioned the Indian perspective, the challenges, which is the biggest challenge is the undertransfusion and inability to maintain the optimal hemoglobin. And of course, the prevention has to be the goal only. And of course, I agree with you, and you have very nicely said, both the speakers, that we have to avoid doing splenectomy. I was remembering when we were talking about that, my memories went back to late 1980s. At that point of time, the situation was such, and the management ethics were not in that great place, that whenever there was the doctors used to find a problem in that the patient is not able to maintain properly the hemoglobin and all that. So I remember that I went to Whittington Hospital. Dr. Wonky arranged. Dr. Cochrane was the surgeon there, and the splenectomy was done. But now, like Dr. Amita Mahajan has very rightly said, that we hardly see any patients whom splenectomy is the only option. So I feel satisfied that the patients and the families are understanding the importance of optimal management and how to keep the hemoglobin at the right, on the right, the pre-hemoglobin at about 9.5, at least 9 grams. That is, of course, is happening in the big cities only. So in the end, I would like to thank, first of all, to Dr. Neeta Radhakrishnan for just planning, not only planning, but executing these such eco webinars. And thanks, of course, to Eco India for hosting it. And thanks again to all the delegates. And there were 133 delegates who joined from different parts of from India as well as from the overseas. And I just saw the numbers that till now there were about 99 delegates who are still listening to us. And we, of course, look forward, stay in touch with us and look forward to hear about the next session, which Dr. Neeta has just mentioned. So can I have the reply for maybe some patients are still there in this group? Should we continue giving thalidomide at this point of time, or only under strict protocols, as Dr. Amita has mentioned and Dr. Piga has just said?
My present position is to start ex novo thalidomide is yes, if there is a strong indication for an unmet need with no alternatives. Otherwise, prudence and waiting for the long-term safety we have to collect now. For the patients that are on thalidomide, obviously, first reference is the treating doctor. I cannot say good or not. Yeah, the treating doctor is obviously having in mind what we discussed even today, that is prudence.
I agree, yeah, entirely, that I think in the current era, we should give it under, you can say under the clinical setting of a clinical trial or a study. So they are being followed meticulously, and they have been given the entire consenting formalities. They have been given the pros and cons, because the moment we are on a study, certain more protocols follow. And I think it is obligatory. Even the study that Dr. Neeta and myself, we were part of it. It was done under a clinical trial. And once the trial was concluded, we have sat down with each patient one by one. And this, because what about the responders? Should they continue or not? And this kind of information emerged during the trial. And we have openly discussed with each patient. And then we have documented it so that, and we have highlighted especially the concern about a malignancy later. So I must say that if we give in the current era, it has to be either that there is a dire situation, like, we are trying to avert splenectomy, so we know it is controlled drug for a few months we are going to give, or under the setting of a clinical trial. It is effective, but we don't know the long-term consequences, and we should be honest and transparent.
Thank you. Thank you so much to both the speakers. Over to you, Neeta, if you want to say the last words.
Nothing more, ma'am. So I think there were some queries on how to get updates on the next thing. So on the iEco platform, you will get. Otherwise, just send a mail to that email ID which has been shared, please. So we will put you in the mailing list for ECO. I think that's again from our side. Thank you very much to both the speakers. Thank you again. See you again.
Thank you, Dr. Amita. Thank you. Bye.
Bye.
Bye. Bye.